Good evening, everyone. I'm Christy Alexander, President of the Florida Academy of Family Physicians, and tonight, Florida's family physicians are joined by our colleagues, Florida's pediatricians, to talk about a very important and timely topic, returning to school. Specifically, our presenters will focus on how physicians can help families make the right decisions in terms of whether returning to school in person is appropriate, and if so, how to keep students safe and healthy regardless of their learning environment. The program is intended to stay focused on science and quality care, not politics, with the presenters addressing specific questions associated with assisting parents and their children. And as we know, this is assuming that we even return to school next month or this fall at all, and time will only tell. This evening's webinar represents the FAFP's 10th installment of programming, organized and presented to support FAFP members in navigating the COVID crisis. I'm very proud to note that as of today, the FAFP COVID webinars have generated over 2,500 live and on-demand views since launching in late March, a true testament to our COVID-19 task force and task force chair, Dr. Chris Scuderi, who will be helping me moderate today's session. We know that our success has not occurred in a vacuum. Rather, it's been dependent upon collaborations with content experts inside and outside of family medicine, which is why we've partnered with our peers at the Florida chapter of the American Academy of Pediatrics to talk about this very important topic tonight. Now, before I formally introduce our panel, please remember all participants are in listen-only mode. If you have a question, simply type it into the chat box and our presenters will attempt to answer it during the question and answer period at the end. It is now my pleasure to introduce our presenters. First up will be FAFP Treasurer and Government Relations Committee Chair, Dr. Christy Cavanaugh, who is the Associate Program Director and Associate Professor at the FSU Family Medicine Residency at Lee Health in Fort Myers, Florida. Not only does she have an awesome first name, Dr. Cavanaugh is an excellent physician and educator, not to mention a mom herself working with her husband trying to determine what's best for their own son's return to elementary school this fall. Next is the Florida chapter of the American Academy of Pediatrics President, Dr. Paul Robinson, who is also an FSU faculty member and is the in-house pediatrician at the Tallahassee Memorial Family Medicine Residency Program. Now, I can say that I've known Dr. Robinson a really long time, considering he helped train me when I was in residency. But let's stay focused on how lucky we are to have someone so experienced and so close to family medicine joining us tonight. Our third and final presenter is Dr. Jeff Brosco, who is the Director of Population Health Ethics and Professor of Clinical Pediatrics at the University of Miami's Miller School of Medicine. Dr. Brosco is the principal author of the Back to School Checklist, which we will be discussing tonight, an invaluable resource as part of this conversation. Tonight's format will include 6 questions asked by Dr. Scuderi and me, with Dr. Cavanaugh focusing on the first 3 and Dr. Robinson and Dr. Brosco focusing on questions 4 through 6. Of course, all presenters will interject whenever necessary, but for now, let's get started with question number 1. Dr. Cavanaugh, how can physicians help parents prepare their children for the school year, either virtually or in person?
Thanks, Christy. Well, everyone wants children to return to school safely this year. We know that the benefits of school go far beyond education, with social development, access to food, mentorship, a safe space while parents are working. And the challenge I think we're all grappling with right now is that key word of safely. How do we do this safely? And how and when to return to school safely means different things for different families. And we have a variety of different communities across Florida where that's going to look different. So I think it's important that we acknowledge that the options that parents have are going to be variable throughout Florida. We're seeing face-to-face options, virtual options, hybrid options. And we know that school districts are taking measures as much as they can to prepare for a safe return. And that's going to vary depending on the local prevalence and transmissions of COVID. Now, of course, the million-dollar question I'm sure many of you, like me, have been asked for advice on returning to school and am I sending my son to school and what do I think they should do? Not just from my patients and their parents, but friends, family, random Facebook contacts I haven't heard from in 20 years, just wanting to know my opinion. And I think if there was an easy blanket answer, that would already be standard policy. But there is no one size fits all solution. And so our role as physicians is really to help facilitate the parents' decisions when they're asking us that question. That return to school checklist is a wonderful tool, and we're going to go into some more detail with that later. But it's really asking questions to help parents make decisions that fit their family's needs. Are you concerned about your child's health, the health of family members that are going to be in close contact with your child? Are you confident that your child can wear a mask and socially distance and wash hands while they're at school? If you do choose to keep them home, do you have access to a computer and internet for virtual learning? Do you have a safe child care option if the child is not going to be in school? Will they have a safe space? Or does your child have special needs and accommodations? And consider talking to the school about how that's going to be addressed, whether they choose virtually or in person. I think that we really need to recognize that this year is not going to be a typical school year. This will not be business as usual. And so we need to plan for surprises. School dates opening may change. Schools may close again. Classrooms may close. Children that had opted for a face-to-face option may suddenly find themselves being quarantined at home for 2 weeks because there were positive contacts within their classroom. And we need to make sure we're helping parents plan for that, to make sure that they do have childcare options and start planning ahead for that flexibility that they'll need to have this year. We also want to make sure, and we'll talk in more detail later, that the child is up to date on routine well care and care of their chronic conditions, trying to get them as healthy as possible before going back to school to be ready to learn, whether it's virtual or face-to-face. But particularly getting their health as robust as possible before going back to a face-to-face option. And then it's also our role to try to clarify misconceptions and share information. So there's so much that we're trying to still understand about COVID and transmission rates and how it's affecting children, how it's affecting our communities, how to treat it. And because that information keeps changing so rapidly, of course, it's hard to keep up with. And all of us are still struggling to figure out what the latest recommendations are and what we think we know at the moment. But as informed physicians, we should be trying to share that information with our families that we're taking care of. Next slide, please. I wanted to share this resource. I found this to be the best source that I could find on pediatric data specifically relating to both transmission rates and current prevalence and hospitalizations for children with COVID. It is updated weekly, and it's reported from the Children's Hospital Association in collaboration with the American Academy of Pediatrics. Next slide. These are some examples of the data that you can find in that state level report. You can see, of course, that Florida, as usual, is leading the way with the number of cumulative COVID-19 cases, as well as showing increases in the number of cases. Go ahead to the next slide. This is an interesting way of looking at how COVID may be affecting children and really what percentage of cases we're seeing. As of the report last week, we saw that 8% of current COVID cases were attributed to children, which marches out to about 318 children per 100,000. So we do know that COVID is affecting children. Fortunately, it looks like they are having a milder disease most of the time. Go ahead to the next slide. And you can see that here with the hospitalization rate. So it looks like hospitalization rates for children range between 2 and 3% when they are affected by COVID, according to the data that we have at this point. Next slide.
Excellent. Thank you, Dr. Kavanaugh, for just great information. How can parents keep their children safe and healthy in virtual or in-person learning environments, such as mask, distancing, exercise, nutrition, ideas such as that?
Yeah, so I really like this concept of the 3 W's, and I think that's something that's easy to remember. We can teach our children that and practice it. We really need to practice now and get them into the habit of wearing a mask, washing their hands, and watching their distance. Because if we're going to be successful in trying to reduce the transmission of COVID when we're in those close environments in a school, we need to be able to do all 3 of those things. Go on to the next slide. So I hear the question over and over again, well, but do you really think children can wear masks? Yes, they can. I think they do a really good job wearing masks. I went to the store last week, and as I walked around, I saw just half of the adults with their masks under their nose, on their chin, touching their faces. But every single child I saw in there was wearing their mask correctly. So I think we could learn a thing or two from our children. But we do recommend that anyone over the age of 2 be able to wear a mask if they cannot be fully socially distanced. This is my son on the left. So one of the tips we followed when getting him used to wearing a mask was letting him pick it out, pick fun, bright colors and bright designs. He loves that parrotfish mask. That's one of his prized possessions, that and his Harry Potter mask. My niece and nephew there in the middle were so excited for their character masks, and that little pipsqueak is 3, and he wears it like a champ for hours on end. One of the tips that really helped getting him used to it was starting during screen time. That was when we initially practiced. So that was the agreement his mom had was, well, okay, you need to wear a mask during the entire 30-minute screen time that you have. And so it was a good way for him to get used to it for a set period of time while he was distracted from something else. Doesn't mean that we should be encouraging hours and hours of screen time, but if screen time is something that the family is using in small amounts, that's a good time to practice wearing the masks. Practice with a stuffed animal, let them decorate them with stickers. And don't forget, if one doesn't feel comfortable, try another one. There's so many different styles of masks out there. If the ear loops are bothersome, get one with the 2-tie version or sew buttons on a headband or hat to help them keep it in place. I will add the caveat here. The only times we would not recommend wearing a face mask, of course, children under the age of 2, we do worry about suffocation. But if there is a child with disabilities who is not physically able, if they don't have the motor ability to remove their mask, then they probably should not be wearing a mask. So, and then the final point that I want to make for really preparing our kids to be healthy is to remember overall well-being. These are the things that we family physicians and pediatricians are great at. So let's not forget what we should be doing and encouraging for both our children and their parents is to remember that sleep is important, healthy eating is important, and nutrition, physical activity, exercise, connectedness, and stress management. And I know we're going to go into that a little bit more during one of Dr. Robinson's questions, but we just need to go back to the basics and remember that that is something critically important for getting these kids ready right now. Next slide.
So, Dr. Kavanaugh, how important are vaccinations and the routine follow-up pre and post return to school?
So I will answer that question with very. It is very important. Unfortunately, we have seen that during this pandemic, many families, adults and children, have delayed medical care. And a well-child check is seen as something that can wait till later. And unfortunately, children are behind in their routine vaccinations. Next slide. So the CDC has put out official recommendations on the importance of that immunization service during the pandemic, that even when they recommended cutting back on routine provision of care, that did not include vaccines, because these routine vaccines prevent illnesses that lead to unnecessary medical visits and hospitalizations and further strain the healthcare system. And so it's critically important that we continue those outreaches for routine vaccines. Go ahead to the next slide. Some things that might be helpful are putting up reminder and recall systems. So make sure that you are going through and trying to find your children that are getting behind in their vaccines and reach out, get them into the office and get it done. If you're seeing a child for a sick visit, assess the vaccination status. It doesn't just have to be at well visits. We should be assessing that vaccination status at every visit. And it might be helpful in your practice, depending on how it's set up, to put some standing orders in so that if a parent calls, they could come and get caught up on vaccines, even if they need to delay a visit face-to-face for another time. Now, the caveat to that is if COVID is actively suspected in a child or confirmed, you want to postpone vaccinations until they no longer meet isolation requirements. Now, that's the current guidance on the CDC website. Of course, I would definitely continue monitoring to see if that recommendation changes at any point in the next couple of months. But for right now, that is the recommendation. Next slide. And the FC, oh, go back one. The FCAAP came out with a wonderful statement going through some recommendations regarding school reopening. And I know you specifically had some points about vaccination. So I would love to hear Dr. Robinson's points on that document, specifically with vaccinations.
So thank you, Dr. Kavanaugh. I would just add, why did we do this document? Well, part of it was a little bit of concern that we had not seen very much coming out of the state of Florida. And so a group of 11 of us around the state, including Dr. Brosco and 3 pediatric infectious disease specialists from around the state, myself and several other people got together to do this document to basically say, what are our recommendations about reopening school? We, as many of you know, we wrote the governor, just like Dr. Alexander's written the governor a few times, about a month ago, and asked him to consider holding starting school in person until the levels of infection went down. And in that letter, I promised him that we would present this white paper to him and the superintendents and doctors that were interested in the state. And this paper is what came out of it. And regarding immunizations, one of the very first points is that it's just very important because the last thing we need is a vaccine preventable disease to pop up in the middle of COVID or after COVID. If you know how infectious measles is, for example, or varicella, we already have a hepatitis outbreak in Florida and Kentucky more than any other states. And so the last thing we need is for something else to come up. I would also add that I personally, and I'm sure many of you are too, I'm really, really pushing my patients, even the ones that typically do not get influenza vaccines, to please get them. And I think those of you who treat adults, it may be even more important, because if an adult gets influenza plus COVID, I don't even want to think about the consequences. We don't know yet, but I'm afraid we'll find out this winter. So the other thing I'll say about the reopening, we really tried to stick to data about the reopening issue. And the World Health Organization came out several months ago with the recommendation, based on lots and lots of number crunching from around the world, that regions and societies and states should not open up fully until the rate of positive COVID tests was down below 5%. As you know, Florida is running around 12 right now overall. And so much to the chagrin, I'm afraid, of the Surgeon General, our committee really felt that those numbers needed to be there. They didn't specifically talk about schools, but our feeling as a group was, if we're asking people to wait to go to Home Depot until the infection rate is down to 5%, then we sure don't want kids sitting in school for 8 hours a day with infection rates of 12, 14 or more percent. So that's one thing. The other thing is the New England Journal of Medicine just printed an article yesterday that looked at this issue, and said that actually even lower numbers probably are potentially could be needed. So it's an interesting concept. I guess we'll see what happens, but that's why we did what we did. So I guess I'm up next, so we'll go to the next slide.
So next question, this will be for Dr. Robinson. What is the best way to counsel parents when their child is sent home from school with symptoms and return to school after recovery?
So I think the first thing that all of us would want to tell parents is please don't panic. And easy to say, hard to do, right? Because parents panic when their kids get otitis media or when they get a gastroenteritis at 10 o'clock at night. But it is still important to try to keep them calm, because it doesn't do anyone any good if they stay super panicked about it. It's important to try to convince your parents, and pediatricians have had during March and April, had their office visits down about 80%. I'll bet you that's true of you guys as well. It's picking up a little bit now. But it's important to convince our parents that the benefits of coming to our offices far outweigh the risks, because all of us are doing everything we can to maintain safety for them and their children so that they can get the care they need, both well checkups and if they're ill. We have to remind them, as Dr. Kavanaugh said, that COVID-19 tends to be very mild in children. Many are asymptomatic. A few come in with the same symptoms as adults, with respiratory symptoms. Several present with gastrointestinal symptoms, but only about 10 to 12% actually get sick, at least significantly ill. When this all hit, I called Tom Truman, who's the intensive care doctor here in Tallahassee, and told him that if they need me to help with the hospitalists, I'd be happy to do that. Never got a call. Checked in with him every now and then. He said, we just aren't seeing any kids in our PSEU. And then if we could go on to the next slide, because the last 2 points I accidentally put in twice. As you know, many different conditions can cause the same symptoms. So again, talking to those parents and saying that, yes, it could be COVID, but it could also be respiratory syncytial virus, influenza, good old rhinovirus, metapneumovirus, strep throat, gastroenteritis. There are lots of things. And in fact, hopefully we're going to see the common things more commonly than we're going to see COVID. A very rare condition, as you know, is the multi-system inflammatory syndrome in children. It is, if those of you who remember residency and remember seeing children with Kawasaki syndrome, these kids are sick. They have high fever. They have typically a rash. These are not kids that are going to be running around your exam room feeling good. They're the kind of kid that you walk in and go, oh crap, when you take one look at them. And so in some ways you can reassure parents, because anytime their child's diagnosed, the first thing that's going to come to their mind is my child going to get this MIS-C? They won't know it by that term, but you can reassure them that, you know, trust me, you will know, sadly, if your child is one of the few that gets that. Okay, next slide, please. Oh, so when do you test? And this is a lot of this is from the CDC. I tried to footnote it for you. Hopefully you guys will all get our handout. So when is COVID-19 testing appropriate according to the CDC in children? And it's of course with any individual who has signs or symptoms that would be consistent with COVID-19. Well, I've just finished saying that it can present as almost anything in children. So I guess we have to use a little bit of judgment, but just sort of keep in mind that children can present with diarrhea, gastroenteritis, etc. If you have an asymptomatic individual who has recent known or suspected exposure to a SARS or CoV person, you might test them to control transmission. Asymptomatic individuals who, again, did not have a known or suspected exposure, but you might want to test them for early identification in certain settings, perhaps. And individuals being tested for purposes of public health surveillance, which I don't know if we're doing very much of that now because it seems like we're using all our testing people with symptoms. Note that as of July 17th, the CDC no longer recommends test-based strategies to decide if someone is no longer infected. So if they've had an infection and they're over it and have spent the number of days they're supposed to spend, we aren't supposed to need to retest them. I don't know if that'll stand, but that's the current recommendation. In the guidelines, the white paper is what we're calling it from the Florida chapter. We have this table. I don't know. It's about page 8 or 9 maybe. That talks about what you do with students or faculty or staff member when they can return to school if they have an illness. So I hope you guys will click the link on the paper to get that paper and download it to your computer. Would you go back a slide? I'm sorry, I wasn't quite done there. Thank you. So if you have an individual who's febrile or symptomatic, but you see them and clearly they've got strep throat or a urinary tract infection, it's business as usual, right? You're going to send them back just like you would have normally when you treat those person. If they come in with, they haven't been tested, and they don't have an alternate explanation. So someone has, say, fever or a symptom, you don't test them, but you're not sure what else they have. They would recommend that they remain at home for at least 10 days if they're symptomatic, and they have to be afebrile for 24 hours without the use of a fever controlling agent before they can come back to school. So, and then, of course, someone who's very sick, it could be as long as 20 days. Now we can go on. This is a little smaller print, and I apologize, but if someone's tested and is negative, first of all, if they are symptomatic, then if the test is negative and the symptoms resolve, then they can go back to school 24 hours just like they could at work after they don't have fever. The problem is, what if their test is negative and they keep having symptoms? Then what our ID people on our committee thought is it would probably be reasonable to retest them and then make sure it's negative. And then, of course, they would continue staying at home for the appropriate time until their fever is gone. If they're asymptomatic, then you would just proceed with the with going to school unless they had a close contact that they'd been in contact with for 15 minutes, less than 6 feet apart. And at that point, they need to stay home for 14 days to make sure they don't develop symptoms. If they're treated, tested, and they're positive, if they're no symptoms, they're going to just stay home for 10 days. And if they develop symptoms, then of course they have to stay home for 10 days after they start developing symptoms. If they are symptomatic, then they have to remain home in isolation for at least 10 days from the date of the symptoms that they began, and again, 24 hours without fever. And then the last one is close contact within 6 feet for more than 15 minutes. If they're symptomatic, if the person becomes symptomatic, you're going to go back up to the symptomatic protocol. They'll have to quarantine if they don't. And if there are no symptoms, you're just going to quarantine and watch for symptoms. Could we go for the next slide, please? Okay, what about the family of an ill child? Because one of the big concerns the Florida chapter has is, while it's true that children don't get very sick with COVID and young children probably don't spread COVID very well doesn't mean they don't spread it. So current data from Dr. Park's recent study in Seoul, South Korea, shows that small children below the age of 10 spread this virus at about 5% of contacts. But 10 to 19-year-olds are able to share the virus just as well as we are, at about 17%, which is frightening. I will add that in that study, he had fewer adolescents than he did small children. So we'll have to see if that actually holds up with time or not. Okay. Next slide, please.
So our next question tonight is, how can physicians help support parents who to keep the children from stress and from a stress and resilience perspective?
So I think the first thing is we've got to help parents take care of themselves. It's just amazing how stressful this is for parents, being home with kids who are driving them nuts, trying to worrying about money and trying to figure out how to do their work and how to get their kids educated. So I think one of the biggest steps we can do is try to help the parents take care of themselves. Because if they're not doing very well, it's not unlikely that the child will have trouble too. Remember that kids are just amazingly resilient. I do a lot of behavioral health as an adolescent medicine doctor. I'm sure I don't do as much as Dr. Brosco, and I'm probably not near as good, but I do a lot. And up here in Leon County in this area, it's just amazed me through this pandemic that most of the kids I meet with are doing just fine. The ones with ADHD and depression who are being picked on at school are happy because they're not in school. And it seems like the kids that I see that start having troubles are the ones who have family members who have become ill. And then suddenly it hits home. But I don't know that many of them it's really hit home yet. And so they're kind of having a good time. Try to keep the kids on a schedule. Good luck with that, but try. And maybe doing things like giving them goals or things that they might try to do. For example, starting a project, kind of like the Boy Scouts used to do. Even teaching them a board game might not hurt them. Try to get them to spend a little bit of time outside. I've been astounded. One real negative, I said most of the kids are doing fine. But I've also been astounded since this started, how many of my kids are staying up all night playing video games and then sleeping a lot during the day and really messing up their sleep schedules. So trying to keep them on a good sleep hygiene schedule. And part of a good sleep hygiene schedule is to get them outside every day. Because when you send kids outside during the day, the blue light, ultraviolet light from the sun cuts off melatonin production in their brains. And then it comes back with more of a vengeance when they go to bed at night. So most sleep experts will tell you that part of good sleep hygiene is getting kids outside and getting them active during the day. All right. You want to try to keep them busy. Don't let them spend all day and all night playing games, as we said. Next slide, please. Try not to spend too much time yourself in front of the news or computer. And I need to speak to myself about that as well. Because I don't know about you guys, but it really gets depressing watching the news again and again. It's like Groundhog Day these days, the movie Groundhog Day. And try to limit your child's access to that information as well. Try to support everyone in the family being active. I've even had kids that I've had to reassure that it's okay to go outside and play basketball by themselves because they're a little bit afraid to go out, that they might get COVID. Remember board games? My wife and I actually played Pictionary with our granddaughter on Zoom about a week ago, and we all had a great time. Our granddaughter had never seen Zoom before. I mean, seen Pictionary, because she's used to playing on her tablet. And take some time every day to check in with your kids. I don't know about you guys, but when our kids were adolescents, we found the best time to check in with them was when we were driving somewhere in the car. It seemed like they opened up a little better than they did when you tried to sit with them at home. And please get your parents to limit those damn video games and screens. Again, I've seen kid after kid who's staying up all night and then messing up their sleep schedule, and it's just a nightmare. Amazon actually sells cell phone jails. They're about $10. So a parent can take the cell phone, put it in jail at night so the kid can't get to it. Alternatively, some of the phone companies will actually cut off service to a device at certain times of the day if you work with them on it. So I've had parents with kids with autism that it just turns off at 8 o'clock at night and they can't use it. And that's helped some controlling. Next slide, please. My experience as an adolescent medicine physician is that most of the kids, again, are doing better than their parents during the pandemic. Again, unless someone else becomes ill. And it's kind of interesting, if you remember adolescent development, they are very egocentric. So because they're so kind of thinking about what's happening in their own world, they're not really thinking too much about what's happening to everyone else. And that may be protective. The other thing that's protective a little bit is the personal fable. And just to remind you what that is, it's the feeling that most adolescents have that whatever may have happened to someone else is not going to happen to me. So I'm not worried about getting COVID because I'm not going to get it. And my mom won't let me go out much anyway. And that, I think, sometimes helps with some of their stresses. And that may be the end of my slides. Yep, the good Dr. Brosco.
Excellent. And so just before we go to the last question of the night with Dr. Brosco, I just want to remind everyone in the audience, if you have any questions that you want to ask our excellent panel, please do so now. We're going to have some time after question 6 for the panel to answer your questions. So now is the time to submit them via the chat box. So this last question, question 6 for Dr. Brosco, is what are some recommendations for helping parents with special needs children navigate unique learning environments?
Thanks very much for the opportunity to answer this. And I have some questions for the panel about how you get your kids to stop using electronics. Maybe we can come back to that. I'm going to go through a few slides in a few quickly to get through this. So we're going to talk a little bit more about shared decision making. Dr. Kavanaugh brought this up at the beginning, just a little bit about what that framework means and what our role is as physicians, in some ways experts in medical risk, but also thinking about the risk to children. The message you've heard so far, and we all know, is that by and large kids do really well, and the main issues are the indirect ones. The exception is children with special healthcare needs, and I'll show you some data that helps us figure that out. And then the bigger question is, how do we actually implement shared decision making? What are some of the tasks it can do? And I'll show you our Florida checklist and give you some ideas about what steps you can take. Next slide, please. So this is what the CDC says. This is from the website just yesterday. I downloaded, and you can see that I'm not going to read it because it basically says there may be issues for children having severe illness when they have underlying conditions. That's because we really just don't know very well. Go to the next slide. I'll show you at least one study that begins to answer this question. In the next slide, you can see this is a table that I put together based on a paper that came out from the Lancet just last month. And it was looking at 18 different nations in Europe and about 582 children who were admitted to the ICU. And what you can see is that if you look along the top line, any pre-existing medical condition, so children with pre-existing medical conditions accounted for about 25% of the entire cohort. So that is 75% of the children did not have an underlying condition. But as you kind of go across to where the column is admitted to the ICU, fully half of the children admitted to the ICU had some underlying condition. So kids with underlying conditions were about 3 times, 4 times more likely to go to the ICU. The next few rows are pretty predictable. So chromosomal abnormality, kidney disease, pulmonary heart disease, malignancy, neurological disorders. All these kids are 2, 3, 4 times more likely to end up with severe illness than children without them. But interesting, look at the bottom. Look at immunosuppressive therapy, immunodeficiency, and chemotherapy. There are relatively few kids in this category in the entire cohort, but their risk was much lower. In fact, it was not different from children who had no underlying conditions. So we're just really beginning to understand that there's some conditions that probably create dramatically increased risk, but others may not. For now, it probably makes sense to be careful about any child with a medical condition, but we're going to have to learn this, and the data is coming out day by day. Next slide, please. So shared decision-making. There's a wonderful paper from the American Academy of Pediatrics that talks about shared decision-making in children with disabilities, and the link is there. And again, I'm not going to go through this whole list, but it talks about what our role is as physicians. And if you go to the next slide, there's a nice pictorial that kind of lays out how to think about this. You can see on the far left, the child caregiver decision only, and then on the far right, the physician-driven decided, and this sort of cross between. What we're aiming is somewhere in the middle. That is that we are experts. We're physicians. We know a lot of the underlying conditions and what the risks are. And hopefully we've spent some time with families and their children. We get to know them and what their values are. But on the other hand, at the end of the day, this is the family's decision. And so this isn't about one group deciding everything. It's about how do we work together. Next slide, please. One tool for doing this is what we're calling the back to school checklist. Now, you can see on the right side, I'm not sure if you can read each of these categories, but this is something that's up on our website. It's been translated into Spanish. And this is something that we put together very quickly because we knew parents are having to decide this right now. It was based on over 1,000 families, their input on what are the issues that are most important to them. And that was something we worked with the Florida Network on Disability and Children's Medical Services to put together. And we've had input from both the Florida chapter and from the Florida Association of Family Practitioners. And we're currently working to revise this and include some other categories with some of our national partners. So CDC and Maternal Child Health Bureau, we think we're going to have a nationwide tool coming that is based on the Florida example. The main idea of this is that it was designed to help build a conversation between doctors and patients and families. And the idea is, so we've all had this question, is it safe for my child to go back to school? And then one of the steps you can take is ask the family to take a look at this and fill it out. And you can see that there are a series of statements such as my child's risk of getting sick from COVID-19. And then the first box is very concerned, somewhat concerned, not very concerned, or not concerned at all. Notice that this is based on the perception that the family has. What is their feeling about it? Because that's probably at the end of the day what matters the most. The idea is if you go down this checklist and you see where families are very concerned or not at all, it helps you guide that discussion. There may be some families that have a child with mild asthma, but they're essential workers. If they don't go to work, they don't get paid. They can't pay the rent. They can't get food for the family. So in that case, it's helpful to know ahead of time that it may be in that family's interest for their child to go to school in person. Our job is to help families weigh the risks and benefits. And we're trying to kind of in some ways move away from the question, is it safe to go to school? Because of course there are some risks to going. There are obviously risks of staying home as well. I mean, if you stay at home, but your parent works in a grocery store, then he or she is bringing home COVID-19 potentially. So there are risks to both being at home and being in school. It's always a matter of where the risks and benefits lie. And that's our job really, is to help families think that through. We can try a couple examples of that during the question and answer period. And the last thing I have written there is about providing treatment for anxiety for the whole family. And as Dr. Robinson pointed out, it's often the adults more than the kids who are feeling a lot of this anxiety. Of course, children feed off the adults. And I have to say, you know, I love being a pediatrician, but a lot of times I wish I was a family doc because you guys have the wonderful opportunity to treat the parents as well as the kids. And we know that as the parents go, so does the child. And so your opportunity to directly address anxiety through cognitive behavioral therapy, and I put the words there, SSI and SSRIs. Of course, we all know fluoxetine and the other medicines that help for anxiety, but there are these new studies showing that these single online anxiety treatment. So you go online to the website, you go through a series of steps, there's no clinician involved. It's been shown to be a good first step for dealing with anxiety. So for those of us who are having trouble finding mental health clinicians in our neighborhoods, there's a whole range of things out there that may be useful in the future. I'm going to stop there because I want to make sure there's enough time for questions, and I have some for the rest of the panel, so maybe we'll come back to this.
Excellent. And I want to thank Dr. Kavanaugh, Dr. Brosco, Dr. Robinson so far. This has been fantastic. So we've got a couple questions from the audience. I'm going to start with question one, and anyone please feel free to answer this. So what do you advise parents who are afraid to send kids back to school and figure that they could do homeschool, although they themselves are not teachers and have not prepared to do homeschooling?
Well, I would like to share that I read through our local district's 65-page primer on our district school reopening, on how they're handling certain situations. And I was incredibly impressed. I really think we need to hand it to our district administrators and teachers that they, of course, have our children's best interests at heart, and for their staff and teachers as well. And they are accounting for some of these options. So most of the districts, and Florida, I know as a whole, does offer the Florida virtual school option. There is a difference in virtual school versus the homeschool. So with homeschooling, yes, the parent is the teacher and responsible for the entire curriculum. But with the virtual school options and distance learning options, the curriculum and teaching is still provided by the school district. And I think we also have to acknowledge, like I said at the beginning, this is not going to be a typical school year. I think we're going to be playing catch up for years to come for many of our children, especially those who are already facing disparities. And we are going to have to tackle that as communities on how we're going to catch that up later. I've heard some suggestions thrown out about how New Orleans handled post-Katrina. They had a do-over year because their children were out of school for so long and fell so far behind. And so I do think, yes, being in a virtual option for some children may get them behind what they would benefit from in a face-to-face situation. But we still need to help facilitate that decision-making for what a family is going to be most comfortable with. Any other thoughts from the other panelists?
I think I'd like to add, I think you're right, Dr. Cavanaugh, that the first question is really about the quality of school and that school education experience. But there's also the anxiety part of this, right? And so I think this is where our motivational interviewing skills come in, and having the kind of conversation with the family, tell me more about the anxiety. What is it that you're in particular worried about? And kind of working through with the family what the pros and cons are. I think we've all been in a situation where families have a very strong belief, and just giving facts usually causes that belief to dig in deeper. So when we're meeting that resistance, right, that's when your motivational techniques come in about sort of that almost verbal jujitsu, where you start wondering about things and saying, I'm wondering, how's it going to go when he's at home and he has to learn this thing? I wonder who's going to be able to help him, and how will that go? And just sort of helping the family think through what some of those things are. At the end of the day, it's their decision, but that's one of the ways to think about helping them get to a place where they're more comfortable with sending them to school.
Yeah, I agree. I think absolutely. And one of the issues I've seen with Florida virtual school is it's fascinating to me that kids will spend all day on computers and tablets until you put schoolwork in front of them. And then it suddenly they get very far behind there too. So there's just not a perfect answer. So I really like y'all's answers. Thank you.
Thank you for the great information. So I'm going to ask a personal question on this one. I'm going to take a little license. And what should we tell our parents about fall sports, and what are the best ways to socialize your children? Especially now as numbers are high in the state of Florida, I think a lot of parents are really struggling with what are safe ways to do both. And so I'd love to have some input on those for our patients.
Well, I think the American Academy of Pediatrics just recently released information about sports, which I would be happy to send the link to you and to anyone else who's interested. I personally think sports are going to be problematic this fall, especially those that ask kids to butt heads like football, etc., or really, really, really exert themselves. So I think golf might work. I don't know about football. I'm not even sure about basketball. And, cross country sounds like it would be okay until you've got a pack trying to pass each other. So I personally have a lot of concerns about any sport where kids are not able to maintain that 6-foot distance and are exercising their ventilatory system because they're working out hard. But I'll be happy to send to anyone who wants the recent AAP guidelines, which I just heard about today in a meeting. So.
To your second question about socialization, I think that's one common point that comes up when parents are even weighing about sending their kids back or keeping them home is, children need socialization. And my husband and I have been talking about, well, does it have to be all or none? Do I have to send my son to a school with hundreds of other kids to get socialization when I don't know if they've got family members that are sick or parents didn't realize the child had a fever and sent them in anyways? Or can we control inviting a friend over that we know the family and we talk to the parents to know that everyone's healthy and still have that social interaction, but within a more controlled setting and smaller groups that we feel more comfortable with. So I think it is helpful to get rid of some of that all or none mentality and look at other ways to maintain that socialization.
I agree entirely with Dr. Cavanaugh. I mean, this is really a lot about harm reduction. And look, let's face it, we're in this for the long haul. There may be slight improvement in our prevalence over the next few months, but there's a really good chance it's going to get worse again. So we're thinking 6 months to a year before we can quote unquote get back to normal. So we can't, I don't think, ask especially our teenagers to have no social interaction for that long. So one idea as well is to pick 2 or 3 at most other children that are sort of your pod, and that's your social connection. And you're not going to be hanging out with 15 kids, but you're going to hang out with 1 or 2. And as Dr. Kavanaugh said, hopefully you as a family have talked to that other family and you've agreed to try to keep the number of exposures low, because there are risks to not having any socialization for the next 6 months. That's obviously not good for any of our kids as well.
They'll just spend more time on those.
Wait, I'm going to throw in there, Dr. Robinson, about the I've been trying to figure out, because the kids being on the games all the time. So my youngest is a 14-year-old boy, and if you allowed him to, he would never leave his room. He would just stay in there forever and socialize with his friends that way, which is COVID safe, but obviously drives us all crazy because we're from a generation to go outside. So what I've done recently, and this seems to be working, is each day there's a contract, and the contract says today you must, do the dishes, clear the table, spend 2 hours outdoors, and a list of whatever other things. And as long as he fulfills that contract today, then tomorrow he's earned 5 hours of electronics. And if he doesn't fulfill the contract today, then tomorrow there's no electronics. And so I think one of the ways to do it is to help kids learn to moderate themselves what they're doing with parental controls. And you can change that contract to be based on whatever is important for you and your family. But it is one of the practical ways to try to keep limits on how much time kids spend on their electronics.
Absolutely. I think that's a great idea, because it pairs kind of a positive reinforcement with the negative to try to get your child to do, but you're still going to have to use the jail probably. And then one of the things I really try to push my parents to is, please don't let your kids have TVs in their bedroom and video games in their bedroom, because what are they going to, they're just going to lock themselves in and see you that much less. So trying to get them to do those things in areas of the house where everyone is will help somewhat. Once the TV's there, though, it's kind of hard to fix. So Dr. Brosco, you answered your own question much better than I could have. Thank you.
I was hoping you'd have a better answer than mine.
Well, thank you for the practical advice on that. That was excellent advice for parents. And so I have another question. It looks like this came from Dr. Robinson's slide, so it's going to come to you first. So I'm concerned that every illness will end up with the kid out for 10 days. Without options, they could get very far behind. Do you have any recommendations on how best to handle this?
So I think if you see a child with an illness and you are able to come up with a reasonable diagnosis, then I think that's probably reasonable to do if they're not ill, or say someone has RSV but that's absolutely going to happen in the beginning of this. I don't think there's any way around it. I'm afraid the other thing that we're going to see, and I really pray I'm wrong, but I really think if we open schools in Florida, as we're talking about opening schools, they'll be closed again within 3 or 4 weeks because the numbers will go up so high. And no one will be happier than me if I'm wrong about that. But so I really believe that in the beginning, we're all going to have to keep kids out more than we like. And it's just going to, I think that schools are going to have to be able to help kids learn when they are at home in isolation. I think in Leon, they're buying, as many of you know, a ton of laptops for the kids to take home. And I think one of the reasons they're delaying, it has nothing to do with our white paper. It's because the darn laptops haven't come in yet. But I'm hoping the school systems will be nimble enough that the kids can keep up during those periods. But bottom line, if you see someone and they've got strep or they've got something you can diagnose, I think it's okay to do that and then let them go back to school as per usual.
Thank you. And so the next question is, I have had a senior patients who are taken care of and watching school-age children who are concerned about kids of all ages who come home from school who may be asymptomatic but may be carrying COVID-19, how would you counsel them and how to best protect themselves other than the 3 W's after coming home from school?
Are you talking about protecting the adults or the children? I'm sorry, I didn't quite understand.
I think protecting the adults on this one is the question.
Which, I mean, I think that is a legitimate concern. And that's something that we're considering when you're going through that back to school checklist. Are you concerned about the health of a vulnerable family member that your child may potentially expose to COVID? So that is definitely a concern to discuss. As far as trying to protect them, I still reiterate those 3 W's and using them all together. So masking, washing hands, distancing, and specifically if the child does have any symptoms, they should not be in contact with the vulnerable family members. As far as asymptomatic children, I think this is where we hope that the data holds true, that children are less likely to transmit the virus, particularly asymptomatic children. Trying to maintain overall health, again, going for that routine care and making sure chronic conditions are managed well, making sure everyone's getting their flu shots, and staying up to date on vaccines, all the usual protection that we can do. That is a really tough situation.
Excellent, thank you. And we're getting close to the end of the hour, so I'm gonna jump in for a couple quick questions. There's a couple great questions I'd love to get in, and so we're gonna kind of rapid fire some of these. So this one is, how can we as community physicians support our schools through this? Broad question, but wonder if anyone has reached out to local schools specifically.
So the Florida chapter has talked with, there are several pediatricians around the state that have reached out to local school boards. Our vice president of the chapter this year, who lives in Miami, and the chairman of Dr. Brosco's department have worked with the Miami School Board specifically. And so several of our people, Dr. Mobeen Rathore has been very active in Jacksonville and that whole vicinity, all the surrounding counties. So we do have people in pediatrics who have been involved, but it would be wonderful if you guys in family medicine would also reach out, because we all know that everyone's busy, and so if we can get enough to help, it would be it'd be wonderful. Here in Leon, no one's reached out to me, and I had not called our superintendent. I keep thinking maybe I ought to do that, but it's just been kind of hard to stop this week. So once we got the white paper out, I thought I might give him a call to see if he had any questions. But they are pretty firm on working just with Department of Health. That's what everything we're hearing from them is, that they're taking all of their guidance from DOH.
Thank you. And next question is, if one student or teacher in the class is positive, does the whole class need to stay home even though they've been wearing masks?
I'm not sure I know the answer. Do either of you know the answer to that? I think it's a 15-minute rule, right? If you're around them 15 minutes within 6 feet, those are the ones that would have to be quarantined, I believe. So
I know our district is coming up with very direct algorithms. It's not relying on a physician's note to return to school. It's going to be set by very distinct algorithms. But what I'm seeing looks like if a child's in a classroom with a positive case, that it's very likely that whole class would be quarantined.
And the reason why we don't really know is because nobody knows. The truth is, there's not enough evidence yet to give really good advice. So there is advice from the CDC and from our white paper, but the research is really ongoing on this, and we may know more in the months to come.
We'll have to.
Yeah, we're gonna find. There's gonna be a lot of natural experiments happening, I think.
Yeah, Tennessee is apparently the canary in the coal mine. They've apparently already started school, and their rate of infection is, also higher than we would recommend. So we may learn some things from them. My home state.
Excellent. So one last question, and we'll finish tonight with this question. What are your thoughts or strategies on how to encourage families of patients who choose to delay or decline current vaccinations or preventable diseases?
I'm having a little trouble hearing the question for some reason. I'm sorry.
So, sorry about that. So the question was, how do we encourage parents who do not want to vaccinate?
Oh, Lord.
So there's been I know it's a long question. Let me go through this quickly. So the first thing is, in general, we as physicians, we say, your child is 1 year old, it's time for them to get the MMR, right? So we're presenting as factual what the things are happening. Do you want to get the flu shot by injection, or do you want to get the nasal, right? So we're presenting some choice, but we're saying here's what's planning to happen. And the research suggests that for 60% of families, that's perfect, where we make it clear that this is what you're supposed to do, and families say fine. There are some families that have lots of questions. Those 20% of families, those information seekers, we love them because they're like us, and we love to give information, the pros and cons and benefits and so on. That last 5 or 10%, the vaccine refusers, the research shows the more information you provide, the less likely they are to vaccinate. It's really remarkable. The more you talk to them, the less they want to. And I think for those families, the very best that you can do, again, using your motivational interviewing techniques, are you can ask some questions, but if they seem dead set against it, you're just looking for a little bit of change. And I usually end with, I have 4 children. They get all the vaccines according to the schedule because I know that's the best way to protect their health. And again, it's the best way to protect their health. They get all the vaccines according to the schedule. And I really think that's the best for your child too. And I'm breaking the rule about sharing for my child, but I think this is one of those emotional decisions for families. And I think it's one of those times where they need to hear we're in it with them and we're willing to do this for our own kids. And then you have to leave it, because anything more you say than that, they're just going to dig in deeper.
Yeah, and I agree that alignment is very important. I find that by acknowledging that they obviously care deeply about their child, and they're trying to figure out what is best for their child and keep them safe. We need to acknowledge that. They're not coming in refusing vaccines just to make our lives miserable as their doctor. They are trying to sort through all this misinformation out there and do what's best. So acknowledging that and aligning with them and telling them, I share that I vaccinate my son with all vaccines on time as well, and that I care about their child too. I agree completely.
Yeah. It may be a tough year coming up, because apparently the anti-vax group has now combined with the group that believe the COVID virus is kind of a hoax, and they're working together and stronger and stronger. And because of that, our lobbyist, who I believe also works with you guys, Doug Bell and Amy, have told us we were actually going to try to get the legislature to pass a law to get rid of the religious exemption this coming year. But we were told by our lobbyists this is a bad year to try to do that, because COVID has put these two groups kind of together, and they are even stronger. So we're going to spend this year trying to educate, and then hopefully come back, hopefully with you guys and FOMA, to try to see if we can get the legislature to do something about the religious exemptions.
Thank you. And I'd like to close just asking if each of you have any closing remarks before we close tonight's webinar.
Push your families to get their flu shots so we don't have to worry about whether it's COVID or influenza. And hopefully we won't have too many people with flu and COVID together, which is just a nightmare to think about.
I'll just say, as important as it is that we're encouraging our children to stay resilient and healthy, and encouraging parents to take care of themselves and stress, to make sure that we're all following our own advice and taking care of ourselves and taking care of each other.
I'd like to thank you guys for letting us pediatricians join you. We're very honored.
It has been so nice to have you guys with us tonight. We appreciate you taking time out of y'all's crazy schedules to do this, so thank you.
As a parent and as a family physician, I can't thank you guys enough. This was incredible tonight. There was so much great information this past hour. I just want to thank you, Dr. Kavanaugh, Dr. Brosco, Dr. Robinson, Dr. Alexander. This has just been such an impactful hour and just, I think, really armed so many of our physicians around the state to feel better about talking to their parents and their children about what their options are and how best to approach this. There's just so many unknowns. I think you really did an amazing job tonight arming everyone. So I just want to, on behalf of all the family physicians, tell all four of you thank you for just an incredible job tonight. Just please remember that questions after tonight's session can be emailed to FAFP so the answers can be provided. Furthermore, all of our webinars are available on demand if you go to www.fafp.org/webinars. And so we have all the previous webinars available. As currently shown on the screen, we hope you will join us on August 20th for our next webinar featuring the topic Thriving in the COVID-19 Marathon. We have three excellent panelists, Dr. Carrick, Dr. Gross, and Dr. Padden, and they'll be focusing on the biggest challenges over the past 5 months and expectations of challenges to come, not to mention, and most importantly, advice on how to cope in these rapidly changing times. So it's important. We got to keep encouraging each other. It's a marathon. Registration will open soon, so stay tuned to FAFP Communications. And I want to tell everyone again, thank you for participating in tonight's webinar. Good night, be well, and stay safe. And just appreciate the panelists again. You're fantastic. Thank you.
Good night, everyone. Bye-bye.
Thank you, guys.
Everybody take care, stay safe.
Thank you.